All right. So my talk is a lot less at this high level of all these things that you can do. This talk is much more simple in asking the question from the data we've collected in the registry. How often are we following these practices? I was really struck by Dr. Sadikson repeating several times in his talk, this is what we used to do, but we don't do this anymore. So we used to use multiple phase scanning, but now basically all of our emergency department patients get scanned with a single phase. And he said that with a whole bunch of practices. And I was wondering if, people know how often the rest of us are doing those optimized scans. And Tim was a really important contributor to the work I'm going to share right now. The disclosure you've seen over the last couple of days. All right, so optimizing doses, I sort of alluded to it a minute ago, is a Herculean task if you have a large number of protocols. Singelman's paper in JCR in 2013 kind of described the equivalent of one full-time FTE required to standardize head scanning, or maybe it was just routine head scanning. It was really amazing how much work it takes. And I think anyone who's working in this knows how much work it takes. It's not easy. And optimizing dose is an absolute balancing act. So we heard this morning from Dr. Barrington that increasing potential risk of cancer from CT scanning is a real risk, and potential risk of having a meaningful abnormality being missed if the dose is too low is also real. And I want to emphasize that both of these risks, the potential risk of developing cancer and the potential risk of missing something, are potential. Neither one of those is well quantified. I think both are real, but neither is quantified. And in the absence of definitive data, we must sort of minimize risk to the degree we can. And for minimizing the risk of cancer, that means minimizing the doses. So how well are we doing at optimizing doses is really this talk. So you've heard from today, also several talks yesterday on well-established techniques for radiation dose optimization. And I'm going to go through some of them to see how well we're doing. First, one that actually I haven't heard so much about is using size-specific protocols. It's not that easy to really optimize dose across the entire span of very petite patients to very obese patients. The same protocol can't really work even with automatic controls that well. And so one approach is to use size-specific protocols where you use protocol A in smaller patients, B in medium patients, and C in larger patients. It's used particularly for children where it's easy as a grab and go approach, so you pick the right size protocol. Next, which we have heard a lot about, modifying tube current based on the patient size using AEC. Third, modifying KV based on patient size. Here I wrote various approaches because they're both automatic approaches that many vendors offer, but you can always do it manually as well. So just changing KV based on patient size. Fourth, modifying KV based on indication. We heard from several of the talks that we can significantly lower the KV depending on what the indication we're looking for. I think we saw examples of how if we're doing procedures, we can lower it considerably. If we're looking for stones, some vascular indication. So are we modifying KV? Iterative reconstruction, I think, has enormous potential. I also think it's pretty tricky to use well. I think it takes a lot of time. So how well are we using iterative construction? And then limiting phase to only those that are necessary. These are several approaches that you can use to lower dose. I'm going to show you most of the results from a paper that's just been accepted for publication. It uses data from the UCSF International CT Dose Registry, and it focuses on one indication, routine abdominal CT. I often focus on this indication because it's the most common indication we have for scanning, and because abdomen uses much higher doses than either head or chest. And then what are the reasons for excess dose to patients, and what are easy tips for reduction. The title came from the journal. We had a much more long, complicated title, but they said that's the purpose of your paper. How can we reduce the doses? So for this sample, where we're assessing how well strategies are used for dose optimization, these data are using data from the registry from 2016 to 2020, so very recent data. There are about 748,846 exams included. These exams were performed with 1,033 unique protocols. I remember showing you a little bit of this study yesterday. And we divided patients into different groups, primarily in two ways. First, by their size. So we basically lined up patients from the smallest to the largest. There were 748,000, so we had 74,800 in each group. So the lowest decile is the smallest, and then the 10th decile is the highest. We then had patients line up again by the dose they received and looked at how the patients who were in the lowest dose group looked like and the patients in the highest dose. The purpose is to try to understand what factors were varying by size or it contributes to the dose. And so the three that I'm going to really focus on is how often did the practices follow protocoling where they limited protocols to patients of different size. Second, how often did they modulate MAS based on patient size? And then third, how often did they modulate KV based on patient size? And I'll touch a little bit on multiple phase scanning, but I talked about that mostly yesterday. So this slide shows the results for the deciles, the groups of patients that we sorted based on the patient size. So in the first group, where it says first decile, 0 to 9%, those were the patients who were the most petite in our registry. Their average patient diameter in that first decile group was 24 centimeters. If we go down to the bottom row, the 10th centile, these are patients in the 90th to 99th percentile, and those patients' diameter was twice as big, almost 40 centimeters. So these were basically the pictures that Tim showed us of the smallest patients and the largest patient in those images. One patient fills out all of the field of view and the other is quite contained. And this table is showing you how did the specific settings and how did the measures of dose vary. And we'll go through them one column at a time. At CTDI-vol went from an average of 7 in the 74,000 patients who had a routine abdomen CT, who were the smallest, to a value that's 3 to 4 times higher in the 10th centile. And the last row shows the average change in decile. So as the group of patients went from the first to the second decile, the CTDI-vol increased 15%. The SSDE, I haven't talked about this very much. That's a measurement that we use that takes into consideration patient size. And in that, we see the differences in the CTDI-vol is smaller because we've now taken into account patient size. But it still shows, even after taking into patient size, the SSDE increases from 11 in the smallest patients to 22 in the largest patients, 8%. The reason it doesn't eliminate all of the SSDE difference across the size is because we tend to use much higher doses in larger patients. That's even larger than they might need because of their size. The next column, it's a variable that we use in our work, is size adjusted CTDI-vol. This takes into account the differences in practice across different physicians by patient size. So CTDI-vol adjusted is the same across all the size deciles. So that just shows that we do a good job of adjusting for size with this measure. The DLP goes up almost fourfold from 400 to 1500. In the bottom row, you can see that increases 16%, MAS 11%, effective MAS, which is MAS divided by pitch, 13%. You can, it's not my main place of showing this, but you can see KVP, surprisingly, doesn't change between the smallest patients and the largest patients, meaning KVP is not modified by patient, only 1% going from decile. So this slide shows you that for the most part, we are changing parameters based on patient size, which is what we should be doing. So this next somewhat busy graph is meant to answer the question about whether size-specific protocols are used. So I mentioned that using size-specific protocols is one way to easily adjust the doses. This slide shows on the x-axis each little tiny line. You can see them best in the right, where you see the very jagged red and green in the right, shows you each of those lines is one protocol. So this is basically 1,000 protocols, 1,033 lined up. Let's start on the left. The first box, that's a vertical box that's blue, is showing protocols that are used only in small patients. And 2% of protocols are only used in small patients. And by small patients for this graph, I'm grouping patients into three groups. Small is the lowest 25%, average are 25 to 75%, and large is greater than 75%. So these are three groups. Half the patients fall in routine, the medium group, and a quarter of patients fall as small and large. We would expect that if we were using size-specific protocols, we'd have maybe 25% of protocols only used in small groups. In fact, it's 2%. The next group are protocols used only in average size patients. Remember, there are a lot of patients in that average size group, 50% of patients. And that protocol is used more than in the small patients, but not that much. 17% of protocols are used only in medium-sized patients. And the vertical green shows that the protocol in large patients is used as 6%. The next group show the protocols used in two categories. The y-axis is the percent, so that blue, red, and green are 100% are used, and there's the next group, it's about half and half. Half are used in routine, half in large, and then the next group are how many. This next analysis was to look at whether MAS varies by patient size. And this graph shows the average MAS in the red dots, the 75th percentile of MAS in the green, and the 25th in blue by patient diameter. So I told you that less than 25 centimeters is the smallest group on the left, and it increases, the red goes up over time to greater than 37 centimeters in the largest group. And you can see that MAS, when you look at it by patient size, goes up with size. I point out one subtlety, which is in the last two deciles, there's an acceleration in the change in effective MAS with size, meaning we're using even larger MAS values than would be expected based on size, which we use higher radiation doses in our larger patients, even more than would be expected. So this shows that we are changing MAS by patient size, albeit maybe a little generously at the high end. If we add to this slide the values of KVP by the same patient size categories, that's a horizontal line at the top. And that line is showing you basically the 25th, the 50th, and the 75th percentile. Not all patients, but almost all patients in our registry have a KVP of 120 by, it didn't matter what the patient size. We're not adjusting KV by patient size. If I look at the dose, the same dose table that we looked at earlier where we had sorted the patients by smallest to largest, we saw the smallest patient were smaller and they had lower doses, and the higher doses were used in larger patients. Here the sort is by dose. We've sorted patients into what were the 10% of patients who had the lowest dose, the next decile, all the way up to the highest dose. I think people might expect to see in the first column, patient diameter, that the patients got larger, that the reason we're using higher dose in some patients is because they are so large. That's not what we found. The patient size, the gray column, was almost the same across the low, medium, and high dose categories. What that means is that the reason some patients are getting high dose is not because these protocols were accounting for their size, but rather the other technical parameters were being adjusted, and that's why they had high dose. There are two rows at the bottom. The second to the bottom says, what was the percent change between the first and the 10th decile? And patient diameter shows it's 1%. It really didn't change. The next 5 columns that are highlighted with light green at the top show the different measurements of dose, and the blue columns show the technical parameters that got to those differences in dose. And we'll go through them one at a time. So first, DLP, we've sorted these cells by these patients, these deciles are sorted by dose. So as we expect, the dose increases from the lowest 295 to the highest 1892. So there were patients who were getting more than 5 times the dose. The percent change from first to 10th centile is 541%. A huge difference given we have one clinical indication, routine abdomen, and we've adjusted for patient size. There is no difference in patient size. These patients are all the same. They're all average size, and the average change per decile is 23%. So this column is just to say that there's tremendous differences in the doses that we're using day in, day out across the 166 facilities that we've shared data from. The size adjusted dose, if you look carefully, it's a little different than the DLP, but not very much. That's saying that even when we take into account patient size, the DLP is still drastically different from the lowest to the highest. CTDI vol, again, goes from 7 to 20. That's 194% change from the first to the decile of 13%. Size adjusted CTDI vol, a little bit less, but not very much. And then effective dose is 592%. I mean, some patients are getting doses that are nearly 6 times higher, meaning associated with approximately 6 times the risk, and we don't really need that extra dose. I wanted to point out now the KV values, which is we absolutely see some patients that are imaged with low KV, and routine abdomen is not one of the situations where we really, really need low KV. We can use lower KV if the patients are smaller. But you can see these numbers don't differ very much from 120. The reason they're odd numbers as opposed to being all 100, 110, 120 is because these are averages of protocols. So each row reflects in the ballpark of about 100 different protocols. Each row reflects not all the same number of patients. They're different, slightly different number of patients in different groups, but they're almost the same. And KV is the same. 115 means sometimes they used a value less than 120, but mostly 120. Scan length doesn't change. Scan length is also like KV, 4%. First to decile, it's 5%, not very much. And then the number of phases is 149% increased from the first to 10th decile. So the number of phases is the largest difference in dose. Depending on the number of phases you use, that has the biggest impact on the dose, followed by MAS, and KV is almost non-existent. And meaning we're not utilizing KV in a way that we might be able to. So MAS, effective MAS, are modulated by patient size. KV is rarely modified, even when the technology is available to make it easy to do so, like where there's specific software that has been put on the machines, it's not used. Size-specific protocols are rarely used, not never, but less than a quarter of patients. Non-indicated multiple phase scanning is typical, and thus known approaches for reducing patient dose are not being followed. I think we've learned about basic things that you can do. We've learned about more sophisticated things that people can do. But overall, we're not doing a great job of optimizing dose using very well-known strategies. I want to share just a few more slides on one other analysis. This was led by Dr. Wang, who's part of my research team. And this is looking at CT acquisition parameter selection and the impact on radiation dose based on decisions that are made. So this is looking at, the sample is 1.3 million consecutive CT exams for routine abdominal CT from those institutions, looking at exams from 2015 to 2021 from 155 institutions, and this is only in adult patients. And the purpose of this analysis was to assess the variation of the different parameters, KV, MAS, spiral pitch, number of phases, and scan length, and their impact on dose in theory versus practice. And so we had 3 ways to assess impact. The first, to reflect the theoretical impact, we estimated what the impact on dose would be if a parameter changed 10%. The second, what would the impact on dose be if a parameter changed 15%? And those are two theoretical. The last one is sort of an important typo, is to reflect not the theoretical impact, but the practical impact, what actually happens. We estimated the impact on dose if a parameter changed 1 standard deviation. The assessment of the first and the second of these two illustrate the raw theoretical relationship between dose, and we use DLP as the measure of dose, and the CT acquisition parameter, like MAS. So if we increase the MAS by 10%, we expect the dose to increase by about 10%. Conversely, the third one doesn't assess these theoretical relationships. The third one captures how much this relationship manifests in the variation of DLP in common practice. So an acquisition parameter, which in practice is rarely manipulated, or only slightly, may be minimal impact in number 3, even if it were highly impactful in number 1 and number 2. So the goal of this analysis is to understand which of the parameters are really important in actual application. And I think you're going to be able to guess what the results are, but I think they're interesting. I need to just clarify one of the statistics before I show you the result, and that's the statistic of the standard deviation. The standard deviation, because that's what the third construct measures, if things vary by 1 standard deviation. The standard deviation is a measure that indicates how variable the data, how dispersed the data around the mean. This graphic shows children and adults of different heights. There's a maroon horizontal line, which shows the mean in this example. And the standard deviation reflects how much these individuals vary from the mean. Are they higher, or are they lower, or are they all about the same? I think looking at this graph, I would say they're not that similar. There seems to be a lot of variation. Low standard deviation indicates data are tightly clustered around the mean, and high standard deviation indicates data are more spread out. So if instead I showed you a graph of the body temperature of humans, and I showed men and women and different races and ethnicities and education levels, we would say that everyone's body temperature is pretty much the same. It's not exactly the same. It definitely varies, but not very much. So the standard deviation of height is pretty high. The standard deviation of body temperature is pretty low. For routine abdomen CT, MAS has a pretty large variation. I showed you in those graphs how much it changed from the small to large patients, or the low dose to the high dose, and it has a much larger standard deviation than KV. In clinical practice, the variation of KV is very little. Greater than 80% of exams in our registry have a KV of exactly 120, and 58% of imaging facilities and over 60% of scanners have more than 90% of the exams having a KB of 120. So the standard deviation doesn't vary for KB. So this is the results of the analysis, looking at the impact of changes in the CT acquisition parameters on the dose-link product. So the first row shows how much the DLP will change if you increase the parameter 10%. And if that parameter is KV, if you change the KV by 10%, the DLP will go up by 29%. So it's a pretty impactful parameter, and we know that the dose is proportional to that, to KV squared. For MAS, inverse spiral pitch, number of phases, and scan length, the impact of a 10% change is much smaller. You'd expect it to be about 10%, and it's kind of in the ballpark of 10%. If we change the acquisition parameter by 15%, the KV would change by 40. If the KV were changed by 15%, the parameter, you'd expect a 45% of DLP, whereas you'd get changes in the other the contribution to the dose from the other parameters changing by 15% would be about 15%. The last line shows what would the change be in the DLP if we change the variable by 1 standard deviation, by the amount that in this population we actually see the variation. And lo and behold, KV, if you increase by 1 standard deviation, the dose only changes by 20%, whereas MAS, it's a whopping 64%, spiral pitch 22%, the number of phases a whopping 45%, and scan length 24%. So theoretically, KV is the most impactful parameter, 29% increase in DLP per 10% increase, versus much smaller for the other parameters. In real world practice, KV is really non-impactful. It's just not changed very much. This graph is showing those same results. So the purple box shows exams. Actually, I should say just on the x-axis, notice the numbers of KV. The center is about 120, see a lot of points there and then small clusters away from it. And then the graph on the right is MAS. You see a much more even distribution of data across the entire spectrum. So the MS changes from, 50, 100, all the way up to 500, where most of the data for KV is clustered in the middle. So the purple box highlights exams where the acquisition parameter is within 10% of the geometric mean. The blue box is 15%, and the yellow box exams within 1 geometric standard deviation of the mean. The yellow reflects the observed data, very wide for MAS from about 100 to 250, pretty narrow from KV, varied from 110 to about 125. So really distribution. You can see that the variation of MAS is far greater than 10 or 15% of MAS, where the variation of KV, the yellow, is much smaller than even 10%. So KV is rarely manipulated, and we therefore lose the opportunity to use this as a dose optimization. So when we look at this graph, this table again, we see the last line, DLP increase per geometric standard deviation increase. KV only contributes a small amount to the variation in the observed dose. That's a real opportunity. So the last topic I want to touch on is how we identify what's a really good protocol from the data that we have. We don't have data on the images of each of these exams. All of these protocols were used in the registry, and for these analyses, so this last slide is an analysis showing how the protocols that we identified as grouped together using something called k-means clustering helped us identify protocols that were optimized and those were not. This graph on the y-axis is showing what we call practice culture. I heard Tim reference it in his discussion as well. This includes a combination of how many scans you do, the phases, and the scan length. And on the x-axis, it reflects the acquisition method. So it uses the results of the MAS, the KV, the pitch, the collimation to summarize the acquisition. And the k-means clustering as analysis is use these 6 primary variables and ask the software to identify protocols that are similar to each other and dissimilar from others. Those protocols are not evaluated based on the DLP. They're only evaluated by MAS, KV, pitch, collimation, phase, and scan length. But I'm graphing the mean of those technical parameters, and I'm sorting those clusters by the size-adjusted DLP. So in this graphic, there are 9 clusters. The software said of these almost 1 million scans, they form into 9 groups. And each of those groups has a center point, and the center reflects the mean of the size-adjusted DLP. And the circle reflects the distribution of the 90% of exams that fall within that cluster. And you can see a few things. First, you see, and I should say that they are sorted color-wise, going from the lowest dose of blue, you can see in the legend, going to the highest dose in red. So the two high-dose protocols labeled 8 and 9, you can see, are actually occupying very different places of the graph. Number 8 are protocols for routine abdomen that are all the way to the right. They're having a variable of acquisition method that has high values. It looks like the acquisition method is around 400. The protocol number 9 cluster is not having high acquisition. That actually has doses that are kind of on the low end, around 180, but has really high practice culture, meaning you can see the y-axis, it's about 3. So typically, these protocols use 3 phases. And then if you look within the cluster, if you look at protocol 1, but it's not that far from 2 and 3, sort of in the center of that blue. These are protocols that use both a single phase and average and lower technique. And this is the approach that we're using to try to tell stories with the protocols, to find the ones that seem to have a good balance of practice culture and acquisition method and results in low phase. Again, we don't have the images, but our assumptions that these radiologists are finding these images satisfactory, I think is a reasonable assumption. So in conclusion, despite the potential impact of KV on radiation dose, this parameter is rarely manipulated in common practice, and this potential remains untapped. KV has the potential to strongly reduce radiation overdosage, theoretically more so than similar degrees of modulations of the other parameters. Despite this, it rarely occurs in practice that it's modulated. Protocols are not tailored to patient size, meaning most protocols are used across all patient groups, and there's another untapped opportunity. And multiple phase scanning remains substantially overutilized, with scan phases being used that are not justified. In conclusion, we need to do better. And the easiest way to do better is to simplify our protocols using well-known approaches. Use size-specific protocols, use lower KV, and de-implement multiple phase scanning. I would say the last one more time. The easiest way to make changes when you go back to your practice on Monday is to remove multiple phase scanning, particularly for emergency department patients, but also for the most common indications of imaging, like a routine abdomen. Removing the repeated scans, like scanning a sinus and a head CT, is still incredibly common, and removing those phases would have an impact on the most common study we do, which is in children, which is a head CT. Thank you so much for attending and for your interest. And I apologize for the challenging technology. So I see a couple of questions. Thanks, Rebecca, for the valuable presentation. Just a quick question. How the effective doses were estimated is shown in the results table. The method of conversion from DLP to effective dose. So I believe the way it was calculated is I mentioned that we have sent our dose data to the University of Florida lab, who has helped us calculate effective dose using Monte Carlo modeling and the technical parameters of the scanners to estimate organ doses and then sum those up to get an effective dose. That's the way we are currently doing it, but in some of our earlier work, we used a different approach, which is Radiometrics calculates effective dose using the approach used by the national accrediting body in the UK. That's the software it has inside, and that uses a similar approach, except not with quite as many robust mathematical phantoms, but rather a much more restrictive phantom library. So we're using one of those two approaches, and I can't remember in this paper exactly how we do it. We do have two papers using conversion coefficients, but we haven't yet used that in our work. And Dr. Kai Yang would like to know, can you elaborate on how you would lower KV will help on reduced dose, especially high dose cases are from larger size patients? So I want to just clarify something, which is the assumption that the reason for these high dose protocols is the patient size. You need higher dose in higher patients. And I don't think you should take that away in your higher patients. You need higher KV for at least some of those clinical indications in obese patients. The data that I showed you showed, even after accounting for patient size, the high doses had nothing to do with patient size. They have to do with keeping the KV 120 as opposed to modulating it from 100, even lower in some patients, particularly smaller children, or lowering it in indications like looking for stones or looking for the needle in a procedure. So the large patients have higher doses, but that doesn't account for the dose variation I showed you. So in your practices, you want to make sure that the dose you use is appropriate. And most patients who are getting higher KV are actually larger and need it. It's rather that the 120 is not reduced for smaller patients. So the next question is, explain about not using multiple phase in abdomen and pelvis. So there are obviously many different reasons that we scan patients' abdomen and pelvis, but a few of the most common reasons are routine indications like suspected appendicitis, suspected pain, possible abnormality of bilirubin or LFTs or pancreatic function tests. All of those study types are a single phase study. In most trauma cases, when you're looking at the abdomen, those are single phase studies. There are many studies that can be done with one phase that we don't for things like, I was going to say hematuria. Hematuria is an area where there's a lot of disagreement, but you can absolutely do that with 2 phases and not use 3 or 4 phases. I'm not sure if you can't get away with a single phase and a split bolus exam as well, but that one's not exactly agreed to by everyone. But the other ones I said, pain, abnormal lab values, trauma, those are all single phases. Those are not multiple phase exams. I showed yesterday that we started doing multiple phase exams really on a little bit of a whim by doctors saying, oh, look, I can see other things. But that doesn't mean that we're helping our patients by seeing other things. If we're looking for surveillance of cancer, another one for most cancers, single phase, if we find 12 versus 7 small nodules in the liver, there's not any data that shows that that's better. So most reasons we do abdominal and pelvis scanning should be single phase. And we use multiple phase in practice, we, the radiology community, very, very often.